Assalamualaikum warahmatullahi. Can we start, Doctor?
Ya. Okay.
Okay, Assalamualaikum and welcome I bid to our supervisor, Associate Professor Dato Dr Fadzil bin Abdullah and my fellow
Orang
friends.
semua ni.
26.
Okay. Dia.
Okay, so before we go further, let's begin with Ummul Furqan Al-Fatihah.
Your file group apa?
Sorry, Doctor.
Your file group apa? Your file group apa?
Group apa?
Group C.
C.
Yes.
Block C ya, block C.
Block 2. Block 2.
Tu.
Block 2. Group C.
Iya ke? Siapa ya? Child breathless siapa yang present?
Siti Nur Izzah.
Siti
Nur Izzah.
Nur Izzah. Okay. Ini berapa bulan? 9. Okay.
Okay, for this afternoon, for PBS 6, we have two topics, child with breathlessness and child with cyanosis. Okay, next. So we start with child with breathlessness by me. So this is my simple outline. Next. Okay, for introduction, breathlessness, or in medical term is known as dyspnea, is the feeling of uncomfortable need to breathe, or from American Thoracic Society, it just convey the same meaning, which is the subjective experience of breathing discomfort that is comprised of qualitatively distinct sensations that vary in intensity. So this feeling, this experience of breathlessness is influenced by multiple physiological, psychological, social, and environmental factors. Okay, next. When a pediatric patient comes with chief complaint of breathlessness, what history should we ask? So start with history of presenting illness. We should clarify on the dyspnea. The first one is onset and duration, whether it is sudden or gradual. For sudden onset of breathlessness with choking, this suggests upper airway conditions such as an aspirated foreign body, allergy, or irritant exposure. While for a child who gradually develop the symptoms, the differential diagnosis may be asthma, bronchopulmonary infection, lower airway foreign body, and we also should think about other system. For example, in cardiovascular, heart failure. In hematological, maybe due to anemia of some disease. And next is whether the dyspnea occur at rest or when the patient is doing exercise or any activity, whether the patient is eating, whether the patient was playing with friends. So we should clarify on that. And we should ask whether it is the first time, the first episode, or there are previous episodes. Next, we should ask on contributing history. The first one is trauma. A history of recent trauma suggests specific diagnoses, such as pneumothorax, pulmonary contusion, intra-abdominal injury. So this is very important to us, any history of trauma. And we should not forget to ask if the patient has a history of playing unsupervised, because the trauma may occur when the patient is playing unsupervised. And next is recent travel. This is also important to help in our diagnosis, because approximately 20% of recent travelers develop respiratory infection. And if we know the place where the patient go travel, it may help with the causal, the pathogen of the infections. And next, precipitating factors, asthma or some disease, we know that it comes with upper respiratory tract infection symptoms. And next, exposure of dust, smoke, allergen, fat. These uh, may suggest an etiology for respiratory distress just now. So for medication on food, the patient may become allergic to the medication or food and become and have anaphylaxis reaction. Next is relieving factor. If the patient has already prescribed with bronchodilator, the patient may have used the bronchodilator at home before come to the physician. Okay, next. Okay, we should also assess the severity of the symptoms based on these parameters. When the patient is breathlessness, how the ability of the patient talking when he or she experience the symptoms, the alertness of the patients. And for accessory muscle usage and wheeze, this is more like physical sign, physical examination. But we can ask parents nowadays, it's not uncommon for them to take video of their children if they are worried about the condition of their children. Okay, so we assess the severity and we can specify it to mild, moderate, severe, or life-threatening. Okay, next. Okay, these are some associated symptoms that are important with history of breathlessness. The first one is fever. Fever suggests an infectious etiology, and rapid onset of symptom in a febrile child is more likely in a bacterial causes such as epiglottitis, bacterial tracheitis, peritonsillar abscess, and cough. The character of cough, like distinct character of barking, whooping, is very helpful in our diagnosis. And next is drooling of saliva, difficulty of swallowing, painful of swallowing. This associated with obstruction, ingestion of foreign body. Next is change in voice. A muffled voice can be seen in supraglottic causes such as infection of epiglottitis, and hoarseness is occur with subglottic causes such as croup. Next is pale or bluish discoloration. Pale indicate anemia, bluish indicate the severity of the hypoxia. And chest pain, this may occur in cardiac causes or maybe due to spontaneous pneumothorax or less likely cardiac tamponade. And abdominal pain, vomiting, increased thirst and urination, these are the symptoms of metabolic abnormality, for example, ketoacidosis from diabetes. Okay, next. So we will look more specific to some differential diagnosis, common causes of breathlessness with their associated symptoms. So the first one is bronchiolitis. It is typically occur in less than 2 years old child, especially 1 to 6 months. The patient may present with mild coryza, low-grade fever and cough. And next one is pneumonia. patient may present with fever preceded by upper respiratory tract infection, cough, lethargy, poor feeding, and severe symptoms of pneumonia are not able to drink or feeding, drowsiness, and convulsions. The next one is bronchial asthma. The symptom are wheezing, chest tightness, cough, particularly at night or early morning, and symptoms of respiratory infection suggest the cause of the exacerbation of the asthma. Okay, next, these are some important severe cause, which are croup, acute epiglottitis, aspiration of foreign body. For croup, the patient may present with barking cough, stridor, hoarse voice, and this disease usually preceded by low-grade fever, cough, and coryza. And for acute epiglottitis, this is a life-threatening emergency condition. The patient may present with high-grade fever, ill toxic looking, dysphagia, drooling of saliva. And next is foreign body aspiration. This is more important in patient less than 3 years old. But for sudden onset of dyspnea, even it is a more older patient, especially with like some problem with mental, we must suspect the foreign body. We must rule out the foreign body aspiration cause. So the symptom for upper airway foreign body, airway obstruction is sudden coughing, choking, drooling, dysphagia, stridor, and for lower airway, the presentation may be delayed 2 weeks. The patient may come with unilateral wheeze, fever, cough due to infection. Okay, next. These are some causes, not in respiratory symptoms, that we must also think of. The first one is anaphylaxis. Anaphylaxis, most commonly caused by food or medication, may be severe and life-threatening, particularly when edema involves the retropharynx or larynx. And in the lower airways, anaphylaxis usually cause bronchospasm. The onset of anaphylaxis is usually within 1 hour, often within minutes. And these are some associated symptoms that can occur, which is facial swelling, urticarial, vomiting, and decreased consciousness. The next one is heart disease. What is important in heart disease, we should bear in mind that the symptom that we usually ask for adult is not the same with the infants or young children. For older children, it's the same as adults, but in infants or young children, the associated symptoms of heart disease is sweating, poor feeding, easy fatigability, poor weight gain. And next is anemia. The presentation may be lethargy, pale, poor feeding, and dizziness. Next. Okay, so we proceed to past medical and surgical history. The first one related to past history is previous episode. Information regarding previous episodes of respiratory distress, including the treatment, may guide our intervention. For example, an infant or child who is wheezing may had previous episode that responded to bronchodilator. So this help in our intervention later. And next is previous hospitalization and treatment, just like what I said just now. And next is any underlying disease. Uh, if we suspect asthma, so history of atopy is very important, like eczema, allergic rhinitis, and heart disease such as congenital heart disease, rheumatic heart disease, any hematological disease or diabetes mellitus type 1 for presentation of DKA. One more important thing about underlying medical condition is a patient with underlying disease usually have more severe symptoms when they develop inflammation of upper airway from any cause. It is usually more severe than a normal child without underlying disease. Okay, next. So other history, birth history, for example, premature birth. Next is immunization history, diphtheria, epiglottitis. This may high. We should have higher suspicion of the of the disease when if the patient does not complete his or her immunization. And next is nutritional history and food allergy, non-food allergy, diet. Patient may be malnourished. And next is family history such as atopy, thalassemia, sickle cell disease. This is important to help in our diagnosis too. Next is social history. For example, in asthma, the home environment and smoke exposure, how the uh, patient in school is very important to assess the patient as a whole. Okay, next. Okay, we proceed to physical examination. So for physical examination, if the patient comes with severe respiratory distress, we should do rapid assessment, the airway, breathing, and circulation, and we should also assess the vital sign, respiratory rate, heart rate. If it is severe, maybe uh, we we can a bit delay lah the weight measurement, and once stabilize the patient, we should complete the physical examination. Okay, next. So this is rapid general assessment, pediatric assessment triangle, which is based on appearance, work of breathing, and circulation to skin. So for the appearance, uh, it's based on normal tone, reduced interactiveness, the consolability, the look or gaze of the patient, and abnormal speech or cry. For this appearance, it is important to note that this is based on child age and stage of development. For example, a newborn has a relatively limited repertoire of behavior. Uh, a newborn unable to fix his gaze or track object. So this is normal for newborn. But for older child, it is abnormal if the older child uh, cannot maintain the gaze at an object. Other important clues such as the infant's tone respond to variation in environmental stimuli. All this is must be based on the developmental appropriate to the age. And next is work of breathing. This describes the child respiratory status, especially the degree to which child must work harder in order to oxygenate and ventilate. If there is any abnormal sound such as stridor, wheezing, abnormal position such as tripod position, sniffing position, and any retraction, intercostal muscle, subcostal, the flaring of the nose, any apnea or gasping. And next is circulation of the skin. It reflects the general perfusion of the blood throughout the body. For example, in the context of blood or fluid loss, compensatory mechanism will shunt blood to vital organ. So that's why it's away from skin and periphery. So the periphery may become pale and become sinus. Okay, next. So this is sniffing position. The neck is mildly flexed and head is mildly extended. This child assume the position of sniffing to maximize the patency of her airway. And the next picture is a patient in tripod position, which is the trunk leaning forward, neck hyperextended, and chin thrust forward. Uh, this also help the patient to maximize the patency of the obstructed upper airway. For both of these patients, they are having epiglottitis. Okay, next. Okay, so this is we can compare normal nostril and nasal flaring. And the picture below is cyanosis, and we also should note the shape of the chest of the patient. Okay, next. Okay, vital signs. So respiratory rate, heart rate is the normal value is varies by age. And tachypnea is important finding in child with respiratory condition. Aside from respiratory distress, tachypnea may be also due to fever, crying, cardiac disease, and metabolic acidosis. And apnea may be the initial manifestation of bronchiolitis or pertussis. Other common etiologies of apnea in infants and young children include choking, breath holding, and head trauma. And next is heart rate. It commonly present in children with respiratory distress due to increased sympathetic tone. Next is oxygen saturation. We measure with pulse oximetry. So persistent resting room air of SpO2 less 97 or less is abnormal in fully term infants and children. And values of 90% and less is indicating significant tissue hypoxemia. Okay, next. So for the vital sign, we should look at the pediatric protocol. In there is already listed the variation of each age. Okay, next for respiratory system, the first one is inspection. We should inspect for the respiratory pattern, the accessory muscle use, and any scar and also the shape of the chest as now. Next is palpation, any presence of crepitus, uh, maybe due to pneumothorax. Tactile parameters, vocal parameters may be increased if there is consolidation. And next is percussion. Dullness on percussion may be due to bronchopneumonia, pleural effusion, and hyperresonance on percussion may be due to asthma, bronchiolitis, and pneumothorax. Next is auscultation. Expiratory phase is a reliable sign of obstructed lower airways that can occur with or without wheezing. And any crepitation and rhonchi is important to suggest the pathology in the lung and the etiology. Next. Next is for other system, it depends on patient's presentation. So if the patient present with um, respiratory distress with sign of cardiac compromise, we should check for the cardiovascular system as well. If the patient come with altered mental status, we should check the CNS. If the patient, if there is no pulmonary etiology is apparent, we should also evaluate for intra-abdominal process, intra-abdominal injury. So we can the finding maybe tenderness, distension, and intra-abdominal injury. Next. Okay, for investigation, next. This also depend on uh, what we what the differential diagnosis, the provisional diagnosis that we have in our mind when we have done the history, the physical examination. Uh, okay, so these are some example: bedside spirometry, ECG, laboratory is full blood count, ABG. All these is depend on what is our provisional diagnosis. Some disease such as bronchiolitis may not need any investigation. And for pneumonia, for example, imaging is the supportive investigation, but not but with it is mainly clinical diagnosis. Okay, next. Okay, for management, the first one is we need to stabilize the patient. First one is airway, ensure the airway is pattern, position the patient in comfort position or manually do the jaw thrust or chin lift. We should clear the airway by using suction if there is any mass copious mucus, and we should opt for adjunct such as oropharyngeal airway or nasopharyngeal airway if the position just now is not enough. Next is breathing. Provide necessary oxygen support, then we must monitor oxygenation by pulse oximetry. Next one is circulation. Monitor the heart rate, rhythm, and we must establish vascular access for fluid administration or medication. Next. Okay, so for other management, the specific management is really depend on the disease, and some disease, if it is not severe, the patient may just treated at home. So this is some supportive management. The first one is antipyretic if the patient has come with fever, antibiotic for bacterial infection. Next, we should monitor hydration status, vital signs, encourage oral intake, and last but not least, the patient and caregivers should be educated about the disease, about the condition. They should know what happened to them. For example, if the condition is not severe, so the patient can be treated at home, but it is important the education. If there is something happen, if the symptoms occur again, so the patient be should come to the caregiver should come to hospital uh, as soon as possible, something like that. Okay, that's all from me. Next. Okay, this is my reference.
Okay lah. Tapi topik is very big lah. You ada briefing tak macam mana nak present PBS? Tak ada? Tak apalah. Tak apa, it's okay lah. Boleh lah. At least you present in clinical setting lah. Tak apa, boleh lah. Next presenter.
Ya, saya sekejap ya. Okay, Bismillahirrahmanirrahim. My name is Wanu Syaira binti Wan Ahmad Khalil, and I'll be presenting about the next topic, which is child with cyanosis. Okay, so this is my outline. First, okay, so this is my outline.
Your file ada seminar.
Ya?
Your file ada seminar lah.
Apa dia?
Seminar.
So, teaching seminar.
Your file seminar tak?
Ada two types of seminar. We have two types of seminar.
Seminar apa you ada?
Problem based seminar and lagi satu teaching seminar.
Di seminar you present lah.
Yes.
Seminar you year 5, year 3 sama tak?
Tak sama.
Tak
sama, lain.
Topik lain? Topik lain ya? Okey, tak apa.
Okay, so I will continue. So this is just a hypothetical figure where a 1-month-old infant presented with bluish discoloration over the lips for 1 day. So this infant presented with bluish discoloration. Firstly, we will think of cyanosis.
Pakai cynos lah.
Sinus.
Topik apa? The child who?
Sinuses. Child with sinus.
Dato pakai blue discoloration.
Okay.
Sinus,
Okay. So a 1-month-old infant presented with sinuses for 1 day. Okay. So sinuses, what is sinuses? It is a bluish purple discoloration of the tissue due to increased concentration of deoxygenated hemoglobin in the capillary bed. Okay, so in sinuses, there is central sinuses and peripheral sinuses. Central sinuses is usually seen on the tongue mucous membrane as a slate blue color and associated with a fall in arterial blood oxygen saturation, and it can only be recognized clinically if the concentration of reduced hemoglobin in the blood exceeds 5 grams per deciliter. However, in peripheral sinuses, the arterial blood oxygen saturation is normal. It only happens because of increased oxygen extraction, leading to increased deoxygenated oxygen at the venous side of capillary bed. Okay, so like just now in our hypothetical case just now, this 1-month-old infant presented with sinuses. As you can see in this table, in this big table, is actually the causes of sinuses in pediatrics. In the pink color is actually cardiac causes, the blue color respiratory causes, and the other colors can be other causes such as hematologic, decreased peripheral perfusion, and altered skin coloration. So there is a lot. So I'll be focusing a bit on cardiac causes first, which is the cyanotic congenital heart disease. It is important because the case is a newborn. So cyanotic congenital heart disease is the most common presentation of cyanotic newborn, sinus newborn. Okay, so the first one is so in this case we see 5T. The first T is tetralogy of Fallot. So tetralogy of Fallot is actually the most common cause of cyanotic congenital heart disease, and it has 4 cardinal anatomical features. The first one is a large ventricular septal defect, and there is overriding of aorta with respect to the ventricular septum, subpulmonary stenosis that cause the right ventricular outflow obstruction, and because
year 5 kan, benda ni semua kan, you dah belajar dah masa you punya cyanosis, everything semua, you tahu tak? You ada kan? Cyanotic heart disease punya seminar kan? You ada ke tak ada?
ada.
So why you want to teach us again all these things?
Okay, so I
The
will
point
skip
is
this.
to solve the problems. To solve the problem is you present macam the first presenter present. From the history HOPI, how you know the history, what type of cyanosis, how you differentiate sign the symptoms is due to cardiac, there is due to lung, and then go on. You don't need to tell us anymore about pathophysiology of these things, because that's not the aim of the PBS. The aim of PBS is patient come with cyanosis, how you want to solve it, problem of cyanosis. Just for presenter present. List down the form from the history, for how to recognize the problems. This one only, this one you dah ada dah, you dah lecture dah beri dah masa seminar dulu, cardiac, year 3 dah belajar semua ni. Go forward.
Okay, so I will go forward.
Okay, respiratory cause. Tu saja you need to know. Buka balik. This one. Okay, respiratory cause. List of respiratory cause. List of cardiac cause. Then after that, you just straight go to the
History.
yeah for your problem solving.
Okay. So just now is the cardiac causes, and now is the respiratory causes. As for the respiratory causes, there could be a few of them, which for upper airway obstruction, it is not in this case, but if the presenting children is a toddler or children who are ambulating, then we could think of foreign body aspiration as the cause. And other than that, we can think of infection such as epiglottitis, croup bronchiolitis, pneumonia. In severe cases, this can cause sinuses. And asthma also in older children can also cause sinuses, so we should think of that. Okay. And the next one is persistent pulmonary hypertension of newborn. It is more in newborn, so we should also, depending on the age, we should think of that. And then trauma can also be the cause of sinuses. Okay, so next is other causes: hematologic methemoglobinemia, polycythemia, and benign causes such as acrosinuses in newborn. Okay, now let's go to the history. Okay, now what history do we need to ask? Okay, firstly, from the presentation itself, we have to know about the age of the children, about the age of the presenting children. If it is a neonate, then we think more of the if in neonate, and if the sinuses is central, then we think of more of the congenital heart disease causes. And in peripheral sinuses, then we think of acrosinuses. Okay, if the presenting age is a children, then with respiratory disorders need to be taken into consideration, such as infection, foreign body aspiration, asthma, and trauma. Okay, now about the presenting complaint. Okay, so the patient presented with sinuses. So what should we ask about? What we should ask is about the onset of the sinuses. Is it sudden? And about the duration, how long does it occur? What about the precipitating factor? Whether the children is crying or feeding at that time, or if the children is ambulatory, does the sinuses is relieved by squatting? In this case, I'm thinking of hypersinutic spells. And also we have to ask about previous episodes of sinuses, if there is, or if this is the first presentation. And also ask if the parents notice any sinuses of the peripherals. Okay. So then we also ask about associated symptoms. When we think of respiratory causes, then we also ask about infection, suspect infection. So we ask about fever. If the patient has history of cough, runny nose, and in group we ask about history of hoarse voice, barking cough. And if the respiratory infection is severe, then we might ask about wheezing or any if the mother notice any chest recession. And severe cases also, the children may have difficulty in feeding and become abnormally sleepy, difficult to wake up. As for circulatory causes, we also ask about lethargy and also about, just like before, hypoxic spells. And also, and then we also have to rule out history of trauma, and also because one of the differentials of sinuses just now is acquired methemoglobinemia, which acquired is more common, so we have to rule out history of ingestion of nitrate containing water, for example, well water. Next, in past medical history, we ask whether the patient has any known underlying congenital heart disease. Congenital methemoglobinemia is rare, so less likely. And also ask if the patient has any known polycythemia, any underlying neuromuscular disease that can cause respiratory muscle weakness. And then also ask about history of, in older children, we ask about history of atopy, asthma, eczema, or allergy rhinitis. Okay. So we then about prenatal history, we ask about maternal drug ingestion because in the case of this is in the case of newborns, they may cause hypoventilation and apnea in newborns. So we have to ask about that. If the mother have any underlying illness, for example, diabetes mellitus, because it is a risk factor for polycythemia. And then next is history of asphyxia or meconium aspiration, because this is a risk factor for having pulmonary hypertension with the newborn. And then for the family history, we ask about family members with atopy in the case of asthma. And also for immunization history, depending on the age of the children, we also ask about vaccination of the children against the Haemophilus influenza in epiglottitis. So on physical examination, what do we examine? So firstly, on generally, we will look on the children's general appearance, whether he or she is lethargic or toxic looking, then we might suspect sepsis or infection or even epiglottitis. And if there is a slate gray appearance to the skin, then we might suspect in methemoglobinemia. And because this patient is cyanosed, so we inspect further on the lips, tongue, and mucous membrane of the children to confirm whether it is a central or peripheral cyanosis. And if the cause of the cyanosis is respiratory, then the patient may also present with respiratory distress. So look for nasal flaring, grunting, recession, and in case of older children who have the tetralogy faded, they may present with clubbing of finger and toes. So we might look at that if we suspect cardiac causes. Okay, next we look on the vital signs. Okay, so if the patient is having infection too, so if the patient might have fever if there is infection, and the children may also be tachypneic. In transposition of great artery, there will be quite tachypnea. Okay, so in pulse, most of them present with tachycardia. And if the patient is hypotensive, then we suspect shock. So for cardiovascular examinations, actually I divided this into based on the disease, but most of them basically, for example, like tetralogy of Fallot, they presented with loud ejection systolic murmur, and they have a single S2 sound. So transposition of great artery also have loud and single S2 sound. They may not have murmur, but some may have systolic murmur. Okay, so this is for other disease. Also, as we can see in tricuspid atresia and truncus atresis, both have single S2 sound. And in tricuspid atresia, there is no significant murmur. But in truncus atresis and TAPPR, if it is not diagnosed at birth, then the infant may develop signs of heart failure. So we need to look at that. Okay, now, so that is for cardiac causes. Now is for respiratory examination. So on respiratory examination, we want to rule out respiratory causes. So this is depending on the disease itself. As per the group, there could be stridor arrest, hoarse voice, mock chest recession, decreased air entry, and epiglottitis, tripod sitting, stridor, and then, okay, so crepitations in pneumonia. And for asthma, look for wheezing, bronchi, usage of accessory muscles. And if you suspect foreign body expiration in older children, there could be unilateral absence of breath sound in lower airway aspiration. And in trauma, ecchymosis, flail chest. For cyanotic heart disease in respiratory examination, there is no remarkable finding. So for abdominal examination, we rule out hepatomegaly if we suspect in right-sided heart failure. And neurological examination is to rule out neurological causes of cyanosis.
I punya ada seorang apa tu nak gazette as a pakar. So I nak suruh dia buat dengan you all 2 bulan PSU. Macam mana arrangement, because you check department lain, ada department lain datang atas tu ikut for gazettement. Nak dia exposure PSU tu. Dia gazettement. Siapa dulu siapa tu? Ayanta Syed, Rosma, main apa tu? Main ke siapa tu? Main semua gazet kat your place. Gazet kat situ. Dan ada yang apa tu ED dia gazet dekat sana. Dekat ED dia orang gazet dekat HTA. ED. Nanti ED saja dia rasa ni gazet kat HTA. anak 2 bulan dengan your PSU exposure tu. Sini tak dapat. Okey. Okey kata. Okay, continue.
Okay, so for the investigation, so firstly for bedside investigation, what we can do is doing full blood count, look at the hemoglobin level, hematocrit level, which could be raised in polycythemia. In case of infection, the white blood cell can be raised and we can look at the differentials to look either it is bacterial bio origin. Arterial blood gases, we look at the concentration of the oxygen, carbon dioxide, pH, bicarb. And then for ECG, it is not diagnostic, but it may help in supporting the diagnosis. For example, like there is a right ventricular hypertrophy in tetralogy of Fallot and transposition of the artery, and there is a left ventricular hypertrophy in tricuspid atresia. Okay, so if we suspect bacterial infection, then we do blood culture and sensitivity. Next is imaging to confirm imaging, which we could do chest X-ray, echocardiography, and cardiac catheterization. So X-ray of chest X-ray we do to confirm pulmonary pathology and in some cardiac malformation. So we can see in X-ray.
Kepada semua Asia Medical Center, para pesakit dan pelawat sekalian. Waktu salat Zuhur akan masuk dalam tempoh 15 minit daripada sekarang. Marilah kita bersama-sama menunaikan solat di awal waktu. Kerana Nabi Muhammad SAW pernah ditanya, apakah amalan yang paling terbaik? Lalu baginda menjawab, solat di awal waktunya. Untuk maklumat, solat fardu boleh dilaksanakan secara berjemaah dan mengikuti SOP yang telah ditetapkan. Adalah dimaklumkan bahawa tiada pelawat dibenarkan untuk melawat pesakit dalam tempoh PKPP. Hanya seorang penjaga dibenarkan untuk menjaga pesakit di ward satu masa. Sekian, terima kasih.
So I will continue. So in chest X-ray, we can see there is a hyperinflation in case of bronchiolitis, and there is a boot-shaped heart finding in tetralogy of Fallot. This is on cardiac congenital malformations, and also egg on a string finding in transposition of great arteries. Okay. So echocardiography is actually the one that will confirm the diagnosis of cardiac causes. Okay. So there is another test that we can do, which is a hyperoxia or nitrogen washout test. So this test is used to distinguish between cardiac and pulmonary cause of sinuses in children. So the arterial oxygen tension is measured in right radial artery, while the patient breathes 100% oxygen concentration for 10 minutes. So if the arterial oxygen tension is improved, then it is pulmonary cause. So it is not cyanotic. It's not cyanotic heart disease. So when we say failed hyperoxia test, then the cause could be a cyanotic heart disease. Okay, so for the management, then we do it for the management depending on the presentation of the patient. Some sinus children may present with respiratory distress, some may not. But in those with, then we do initial stabilization, secure the airway, adequate ventilation, circulatory support, prevent hypothermia. And if you suspect these cardiac causes, we consult for cardio. Then, if we suspect there is a bacterial infection, then give empirical treatment with IV antibiotics. And also, if we suspect that it is a drug-dependent lesion, we give IV prostaglandin E infusion. Once the patient is stabilized, then we can proceed for further investigation such as echocardiography, and the cardiologist will decide on further management depending on the echocardiography finding. This is in the case of cardiac. So I think that's all. This is my references.
20 minutes. Okey lah, tapi boleh expand lagi. The first one is the breathlessness. Actually, breathlessness is I nak tukar esok, child with shortness of breath. Because breathlessness is a sensation, feeling of difficulty in breathing, which the children cannot inform you. But shoulders of breath is more, I think, more appropriate. And then shoulders breath very common. I think you have to define the cause. It's not kadar alang only. It's other thing also which involve also the metabolic. Yeah, if the child got severe acidosis, another one is CNS. The important thing is CNS. If something that involve your respiratory center. Hmm. Tak apa, nanti we discuss of how to ni. And then your I think you start with from when the child coming shortness of breath, the first thought will be the causes. Then after HOPI and the rest, I think other history, there are a lot more other history to look at. Look at not only from the history of asthma. Even if talking about bronchopneumonia, there are many related bronchopneumonia related with a child who stay in the low socioeconomic group, the child who has this large number of siblings, anyone unwell at home, and so on. So many things. And so we're talking about cyanosis. Cyanosis is one of the main. Cyanosis is two things. It can be a symptoms and it can be a sign of severity. So you're talking a lot about the symptoms, but you didn't talking about the sign of severity. Cyanosis can be both sign and symptoms. Symptoms mean that the parent recognize it, but then in examination you found it, so it's cyanosis. And then in cardiac disease, is more or less is a symptoms, sign. But then in respiratory, cyanosis is the sign of severity. In cardiac is a sign of cardiac is the sign of illness, but in respiratory is a sign of severity. So you're talking about cyanosis, your respiratory, you have to discuss a bit about the severity and how you to manage. In cardiac wise, one thing. In respiratory wise, if the child coming with cyanosis, what are you going to do? If the cause is respiratory, so there are the issue. Investigation wise can be expand. Because in can be expand further investigation, not only for it's okay lah. I think for you fine. I think the problem you don't have you don't give you all the guideline how to present PBS. Do we give you a guideline? Tak ada kan? Okay, tak apa. Okay, it's okay. Actually, by right, if when I start the guideline, going to be 40 minutes presentation, 5-minute discussion. So because I believe even seminar also, I'm going to not to let you all go beyond 1 hour and a half. So it's going to be, I'm not sure. I'm not sure. After COVID, are we going to follow? I think seminar we can do as online, continue to do as online, I think, for the seminar after COVID. But PBS, I think, have to do face-to-face. I think that's the only thing we're going to adopt. I think it's not too bad doing seminar with online because it doesn't waste anybody time. For us, we can do it here. It's easy because for us to go away from hospital, it's not. You duduk kat rumah, baring, tidur ni semua. For us, it's different. We like to not to go away from hospital because we have a lot of things to do in hospital. So we need to waste our time to go to the com and so on. You see how it goes post-COVID. Post-COVID, I think will be somewhere August. Post-COVID. You all nak vaccinate tak? Nak vaccinate?
Nak.
Tak vaccinate, you all tak pergi mana-mana.
Nak.
You ada cap vaccination tu, you all tak boleh pergi ni, tak pergi overseas, tak boleh, ada satu tempat you all tak boleh masuk, ni semua. Tak apa, it's okay. Siapa dua sini? Okay, finish. Okay, okay, okay.
Okay, ada. Lupa. Apa tu? Ni jawab apa tu? Left.